Hello, my name is Dr. Neil Phippen, and I'm a gynecologic oncology in the Washington, D.C. metro area. Today, as part of the 2014 Globe-athon to End Women's Cancer events, I'm going to be presenting a clinical overview of epithelial ovarian cancer. To begin with, I want to discuss briefly the origins of ovarian cancer. Pictured here is a picture of a walnut, which I'm using as an illustration to symbolize the ovary, and what I'm about to describe is where ovarian cancer derives from. The epithelial layer of the ovary is similar to the shell of the walnut, and this gives rise to over 85% of all ovarian cancers. There is a support structure within each walnut that supports the actual meat of the nut, and that is similar to what's inside the ovary, referred to as the stroma. And in ovarian cancer, there is an entity called sex cord stromal tumors. However, it only comprises approximately 10% or less of all ovarian cancers. Lastly, the actual nut of the walnut, or the meat, is similar to the bulk or the inside density of the ovary, which is where the germ cells reside. And from that can arise germ cell tumors of the ovary, again representing less than 10% of all ovarian cancers. I bring this up to illustrate the fact that there are other types of ovarian cancer. However, today's talk is going to focus on epithelial ovarian cancer only, which again, as I mentioned, represents well over 85% of all ovarian cancers. First, we will discuss epidemiology, cell types related to epithelial ovarian cancer, how epithelial ovarian cancer is diagnosed, treatment options, and expected outcomes. There's approximately 1 in 70 lifetime risk for women of having epithelial ovarian cancer. This risk can increase if a patient is hereditary carrier of a BRCA1 or 2 mutation. In 2014, we expect approximately 22,000 new cases of epithelial ovarian cancer to be diagnosed. This makes ovarian cancer the second most frequently diagnosed gynecologic cancer behind uterine cancer. Some of the risk factors related to epithelial ovarian cancer include advancing age, and this is primarily a disease of postmenopausal women, often after the age of 60 or 65. A positive family history of epithelial ovarian cancer, never having been delivered a child, new early onset of menses and or late onset of menopause, patients taking hormone replacement therapy. This largely pertains to women taking only estrogen compounds, as progesterone estrogen combination hormone replacement is often protected by the progesterone effect. Patients with a history of endometriosis may be at increased risk, and of course women with hereditary gene defects in BRCA1 and 2, and perhaps other yet undiscovered gene mutations. Protective measures that women can take to avoid or to prevent epithelial ovarian cancer would include oral contraceptive use, tubal ligation, breastfeeding, removal of the ovaries and fallopian tubes, and this pertains really only to the group that is diagnosed with hereditary breast and ovarian cancer, BRCA1 gene mutations. Next, I want to discuss the different cell types of epithelial ovarian cancer. The most common cell type is serous, representing over 70% of epithelial ovarian cancers. There are also mucinous tumors, less than 10% of the cases, endometrioid tumors, representing 10 to 15% of epithelial ovarian tumors, clear cell tumors, less than 5%, and some others. It is important to note that patients with endometriosis, as I mentioned before, have a slightly increased risk of epithelial ovarian cancer, and endometrioid cell types and clear cell types are often associated with endometriosis. How is epithelial ovarian cancer diagnosed? Well, patients may endorse symptoms such as bloating, early satiety, increasing abdominal girth, constipation, or other bowel symptoms. They may have increased urinary frequency or other bladder symptoms from a pelvic mass that may be compressing the bladder. Radiographic imaging sometimes is able to give us information about how disseminated the cancer is, although it is not used necessarily to diagnose or stage the cancer. Modalities such as CAT scan, transvaginal ultrasound, MRI, and PET scan can all give information to your physician. Your physician may also order blood tests such as CA-125, which stands for cancer antigen 125, CA-19-9, cancer antigen 19-9, and then the CEA, carcinoembryonic antigen. It's important to note that the CA-125 is traditionally associated with epithelial ovarian cancer and oftentimes is significantly elevated at the time of diagnosis. However, it is not a very sensitive or specific marker for epithelial ovarian cancer and is most or best used in the recurrence, recurrent monitoring for recurrence, as well as the monitoring for treatment response. Physical exam can be an important part of the diagnosis, especially in patients that have no symptoms. Your provider may be able to detect or palpate a pelvic mass on exam. Additionally, enlarged lymph nodes may be recognized, or in rare cases, metastases to the vagina or the cervix. Tissue biopsy, which may be from the primary tumor, from a lymph node, or from another site of metastatic disease, is also a form of diagnosis. Paracentesis, where collection and analysis of abdominal fluid is obtained, can also give the diagnosis of epithelial ovarian cancer if malignant cells are identified. Surgery really is the cornerstone of diagnosis, which is required for definitive disease staging. So again, epithelial ovarian cancer is a surgically staged disease requiring surgical evaluation to give a complete understanding of the dissemination of the disease. Stage 1 disease is disease that is confined to the ovary. 1A involves only one ovary. 1B would be disease within both ovaries, and 1C incorporates either 1A or 1B in addition to one of the following. In stage 1C1, there may be rupture of the ovary at the time of surgical removal, spilling potentially malignant contents into the pelvis or the abdominal cavity. Stage 1C2 suggests that the ovarian mass has ruptured prior to surgery, or surgery at the time of surgery and pathological evaluation, there is tumor on the surface of the ovary. Stage 1C3 is when there is malignant ascites or washings. So at the time of surgery, fluid that's naturally in the pelvis or in the abdomen or there as a result of the cancer that is collected, and there is no evidence of rupture of the ovary, or there may or may not be disease on the surface of the ovary. Those washings show evidence of malignant cells. In stage 2 disease, you may think that this is considered disease that is confined to the pelvis. A 2A tumor is represented by tumor extension to the fallopian tube or the uterus. A 2B lesion has tumor extension to other pelvic tissues. In stage 3 disease, this is when the disease has spread up into the abdomen and may have a positive pelvic or retroperitoneal lymph nodes. 3A tumor is, a 3A1 tumor is tumor in the retroperitoneal lymph nodes and is broken down as follows. A 3A1I is lymph node metastases where the metastatic focus of disease is less than or equal to 10 millimeters. A 3A1II would be a lymph node tumor size or metastases to a lymph node where the tumor foci is larger than 10 millimeters. A 3A2 disease is diagnosed when there's microscopic tumor spread in the abdomen above the pelvis. 3B lesions are actually visible lesions in the abdomen, but they are small, less than or equal to 2 centimeters in size. And 3C disease, which is the most commonly diagnosed stage of epithelial ovarian cancer, is when there's visible tumor metastases in the abdomen that are larger than 2 centimeters in size. This could include spread to the capsule or surface of the spleen or the liver. In stage 4 disease, there's distant metastases beyond the abdomen. 4A is tumor cells within the fluid around the lung. This would be a malignant pleural effusion. And stage 4B disease is tumor in any location outside the abdomen not qualifying as 4A, which would include the vagina or any non-retroperitoneal lymph node and deep invasion of the spleen or liver. After surgery, your tumor will be microscopically evaluated by a pathologist, and tumor grade is an important prognostic factor. Grade is described as how well differentiated the tumor cells are. Grade 1 is a well differentiated tumor, and these are considered and often act less aggressively. Grade 2 is moderately differentiated, and grade 3 is poorly differentiated, and these represent the most aggressive form of tumor cells. So the treatment for epithelial ovarian cancer is harbored by surgery. And the goal of surgery is to remove, also known as debulk, all visible tumor. This often includes radical procedures such as partial or complete resection of bowel, gallbladder, spleen, lymph nodes, liver, bladder, diaphragm, and the pancreas, in addition to removal of the uterus, ovaries, and the fallopian tubes. It's important to note that at the time of surgery or the completion of surgery, the surgeon will assign an amount of residual tumor, and this has important prognostic implications. Visible tumor implants that are greater than or equal to 1 centimeter at the conclusion of surgery is considered suboptimal debulking. Visible tumor implant or implants less than 1 centimeter at the conclusion of surgery is considered optimal debulking. And the most favorable prognosis is associated with microscopic debulking, where there is no visible tumor implants anywhere in the abdomen or pelvis at the conclusion of debulking surgery. Surgery alone may be curative for stage 1 or 1A or 1B grade 1 or 2 tumors. Unfortunately, this represents less than 10% of all patients with epithelial ovarian cancer. Most patients require surgery plus chemotherapy. Again, approximately 90% of cases or more will require a combination of surgery and chemotherapy. And this is largely in part because 75% of patients are diagnosed with epithelial ovarian cancer when they've already reached stage 3 or 4. The sequence of surgery and chemotherapy is often individualized. Sometimes chemotherapy is given in the neoadjuvant setting, which means before surgery, to help shrink a tumor and hopefully enhance the success of a microscopic or an optimal surgical debulking. Chemotherapy given after surgery is called adjuvant chemotherapy. Chemotherapy routes can be given, can be intravenous or intraperitoneal, and Dr. Bill McGuire has given a presentation on the Globe-athon website about the different types of chemotherapy for epithelial ovarian cancer, as well as the different routes of chemotherapy that should give a lot of information about this topic. So the outcomes for epithelial ovarian cancer are as follows. 75% of patients will have an initial treatment response with complete clinical remission following first-line chemotherapy and surgery. Unfortunately, 65% or more of patients will experience disease recurrence. And this disease recurrence is broken down and classified into 3 different categories based on patients' expected or displayed response to platinum chemotherapy, which is the cornerstone of the chemotherapy regimen that patients receive in the first line. When disease recurs, patients are either considered platinum refractory, platinum resistant, or platinum sensitive. And that is based on the time from completion of primary therapy to the time of recurrence, where the patients that recur well on therapy are considered refractory, and patients that occur within 6 months of completing primary therapy are resistant, and patients who recur beyond 6 months after completing their chemotherapy are considered platinum sensitive. For patients with epithelial ovarian cancer, the estimated 5-year survival is significantly influenced by the stage of disease at diagnosis, the tumor grade, the type of epithelial tumor, patient's age, and the debulking status, as well as the initial chemotherapy response. Stage 1 disease has a very high success rate of cure, with greater than 90% of patients alive at 5 years. In stage 2 disease, approximately 80% of patients will be alive at 5 years. Stage 3 disease, depending on the success of debulking and chemotherapy response, the estimated 5-year survival range is 20 to 50%. Stage 4 disease has less than 20% 5-year survival rates. It is important to remember that epithelial ovarian cancer is truly a chronic disease for most patients. Patients frequently experience multiple recurrences, undergo treatment with multiple chemotherapy regimens, and often require multiple surgeries. It's most important with this disease entity to optimize quality of life, and I recommend getting involved in a survivorship program as early as possible and discussing with your physician palliative care options. This concludes my clinical overview of epithelial ovarian cancer. I hope that you have a better understanding of the disease risk factors, cell types, symptoms, diagnosis, and treatment of epithelial ovarian cancer. I encourage you to get more information from your physician and these websites listed here. The Globe-athon website has a library of informative videos that can offer further details on topics I've discussed today, such as radiation and chemotherapy. Thank you.